Then I want to ask you another important issue, which I at least so understood, that is polyvagal, that there is another vagal part, more the social vagal, so to speak. And when we in medicine, for example, we didn't learn that at that time. Right. And usually always it was also so learned, this is your autonomous nervous system, and that's just individualized. And
it's below the neck.
Exactly, and that's it. But with your results, that was a mind-blowing experience to me, so to speak, to say, then it's a social thing, and also that you can much better regulate these things when you have a certain interactional field.
Right. And I started being very interested in cognitive functioning and physiological change, and then into the notion of self-regulation. And now I'm into the world of co-regulation, because the linkage between the heart and the face, which is part of the polyvagal theory, really is a linkage of co-regulation, using the face, listening to sounds, vocalizing gesture as a way of regulating our physiology. The poly part, which is really what you'd like me to deconstruct a little bit, in more primitive vertebrates from whom mammals evolved, there was one area of the brainstem from which the vagal neurons emerged. One. It is called dorsal motor nucleus, and that's what you learned in medical school. And in medical school, what you learned was very little about the brainstem, but a lot about the target organs. So the emphasis was the autonomic nervous system was a collection of organs and motor fibers. And you were not taught virtually anything about the sensory pathways, and no one taught you about the areas of the brainstem because it wasn't viewed as important, because it was so low in the brain. But the polyvagal theory goes back and reintegrates the history of science about the autonomic nervous system and emphasizes the dynamic feedback loops and the fact that they're being regulated in the brain and influencing other brain areas.
Especially when we talk about therapy now, a lot of people also in my clinic, when we have people with severe traumatic experiences, sometimes tend to go even into an immobilization state. And then it's always a question also for the therapist, how can we relate to them in this state? And when, what I learned from the polyvagal theory is you can regulate hierarchically. So, but on the other side, isn't it necessary that you at first come into contact to the immobilization?
Well, I'm going to we're going to discuss that now. Because if it's hierarchical and you come into contact with that immobilization of fear, what would you do to get yourself out of it? You'd move. So what are some of the therapies that you try to use? Tapping, moving. But moving within a controlled activity. Because if the movement now becomes totally mobilized, it gets into another level. But moving is incompatible with that visceral feeling. So part of the therapy is to inform the client, the patient, that they have a resource, that if they go there, they can come out. And in the sense, so my interpretation of tapping isn't the same as what the people do that.
No, I have the same like you.
but if you move, if they tap the face, it's a polyvagal face, and the sensory afferents for the engagement system, many of them are on the face. So.
Yeah, I think we agree totally because there's so many energy theories or so, but I think it's much more on the neurological level also explainable. So anyway, and so would that mean that in a sense, if somebody is in a very immobilized state, for example, you explain to make a frame of security to him, and to explain that he can come out with that, and maybe in also subtle movements with the whole body, go to the next step, maybe even to expression, and then
the beauty, in a sense, is in the interaction with you. You're the guide. So if a person's starting to go there, you say, move your hands a little, in a dialogue, and say, how do you feel? And what you want to watch for is if there's any spontaneous face-to-face. So if the person starts to engage you, especially with the upper part of the face, then you're there.
Then it's like going up step by step.
Step by step. And so the issue of using mobilization as a voluntary behavior is extremely important, as opposed to using it as a spontaneous defense system. As a voluntary behavior, you can use it as a resource to get out of those feelings. Now, the next part is really, I think, what makes mammals really unique. We evolved to come out of to go from mobilization to social interaction like that, with the healthy one, because we had to. We had to determine who was dangerous to us and who we could embrace.
What would you recommend to us as therapists, or also on this congress with Reden reicht nicht, which means talking is very important but not enough. So it's not that we say talking is not important. It is important but not enough. What would you recommend to us with that?
Well, it's kind of what I said to you at dinner last night. Talking is not enough, but listening helps. Because it's part of the feedback loop. So talking by itself actually doesn't help. But talking with listening and talking with synchronous and reciprocal interaction. So with therapy, talk therapy was kind of like pushed over. If we think of talk therapy and other social interactions as neural exercises of the social engagement system, we see a validity in the technique, not in merely the expression, but in the listening, the reading of cues, and the reciprocal interaction. Because hierarchically, when that system works, it enables the rest of our body, rest of the autonomic nervous system, to support homeostasis, health, growth, and restoration.
But that in a practical way, from my understanding, could also mean that as a therapist, for example, you are not so much distant only to the person, but you are very much in resonance. You go into resonance, you go in tune with it, but for that you have also to keep a certain inner stability, because when you are only drawn with it, it's not helpful, but when you are there, and then you can be a model maybe, that is a resonance in
not necessarily a model, but part of the interaction. So you're the one with the insight to see the cues from the client, and when the cues spontaneously come, you're there to be part of it. And those are the gifted therapists. And what we're really saying is the school of treatment may be less relevant than the intuition of the therapist that picks up on the cues.